Chapter 33, Skin Integrity and Wound Care, Part 3. So please keep in mind that there are psychological effects of wounds on a patient. So the skin is a sensory organ. It is visible for others to see, and the patient may develop a self-image concern or issue. Okay, so that is important. You want to be aware of that and plan for that in your plan of care for your patient. Okay, so also the patient may be experiencing pain, anxiety, fear. It may impact their activity of daily living. And this change in body image is a real concern for many patients with wounds, especially if it's in a visible place. So on page 1167, it speaks about all of these psychological effects of wounds. So health history. So the nurse wants to utilize some guided questions. So we have on page 1169, focused assessment guide 33-1. So each of these areas, it gives us specific questions that we can utilize when we are obtaining our health history for our patient. And then on 1169 at the bottom, it goes into nursing history and just obtaining any history in reference to their skin. Okay, so recent changes in skin, activity and mobility, nutrition, pain, or elimination. For skin assessment, you're using inspection and palpation techniques. Okay, so you're inspecting the skin, right? You're looking for any lesions, any abnormalities, discolorations, open wounds, right? You're also looking for any type of infestation, if there's any bugs or anything like that, because the hair and nails, all that stuff is part of the integumentary system. But you're also touching the skin. You're feeling for warmth, right? You're feeling for any growths, lumps, bumps, any abnormalities. So you are doing this systematically from head to toe, including any bony prominence. And this assessment is done in acute care every shift, in home health care every visit, and in long-term care it is typically done every week. And on admission, all these settings are on admission. But in long-term care rehab settings, it's usually done weekly along with the bath or shower schedule. However, we have on our slide here weekly for 4 weeks and then quarterly. However, I'm quite certain it is done every week, weekly, with the bath or shower. Wound assessment. So, nursing guidelines 33-1 on page 1170, it talks about measuring the wound and pressure ulcers. So we did talk about this briefly in lab, but I want you to read through that as well. So you want to describe the appearance of the wound, right? So the size of the wound, the depth of the wound, whether there's undermining tunneling or a sinus tract. You also want to describe the drainage. So is it serous, sanguineous, serosanguineous, or purulent drainage? And that's on page 1171. There are 4 bullets that describe each of the drainage. I know we did go over that in lab. However, you want to be familiarized with these drainages. You need to know them. You will see them again. Okay? And also on page 1170, in the middle of the left side of the page, when infection is present, the wound is swollen and deep red. It feels hot on palpation and drainage is increased, and the wound edges are separated. You may possibly have purulent drainage. And if the hissing is present, the wound edges are separated. So you want to know that. Again, Infection is present, the wound is swollen, it's red, it's warm, drainage is increased. Any drainage could be purulent drainage. Dehiscing may occur. Of those wound edges. There may also be a presence of an odor. Preventing pressure ulcers. So assess your patient risk daily for a pressure ulcer. Cleanse the skin routinely. So just good skin hygiene. Maintain higher humidity, such as moisturizers, using lotion, right? Protect the skin from excessive moisture, such as incontinence and feces or wound drainage. Minimize skin injuries from friction and shearing. Proper positioning and turning and transferring of the patient will prevent those pressure ulcers from occurring. Appropriate support devices such as wedge cushions, maybe some kind of gel cushion for the wheelchair. Nutritional supplements, and make sure that they are well nourished and hydrated. Improve mobility and activity so that the patient can then shift their own weight or get up at periodic periods of time to relieve pressure. So we have a question, but before I start, I want to call your attention to 1173. It is a Braden scale, which is an instrument used to predict the risk of pressure ulcers for your patient. Most facilities use a Braden scale, and especially our long-term care facilities. In the hospitals, they may have a version of the Braden scale where it determines the patient's risk for developing a pressure ulcer. Okay, so our question: a stage 3 pressure ulcer requires debridement through wet to dry dressing, surgical intervention, and proteolytic enzymes. True or false? And the answer is true. Purposes of wound dressing is on page 1179. So provides physical, psychological, aesthetic comfort, prevents, eliminates, and controls infection, absorbs drainage, maintains moisture balance of the wound, protects the wound from further injury, protects the skin surrounding the wound, may be used as a debridement for a necrotic wound if appropriate, stimulates or optimize wound healing response, and consider the ease and the cost effectiveness. So this is all on page 1179. If I could just backtrack for a slide or two, on 1178, there are guidelines for nursing care and preventing pressure injuries or pressure ulcers. And that's guidelines for nursing care 33-2. So I will read through this entire box. I want to bring special attention to the last bullet on the left-hand side, minimizing skin injury from friction and shearing forces by using proper positioning, such as turning and transferring techniques. Okay, special attention to that. All right, types of wound dressings: those that maintain moisture, those that absorb moisture, those that add moisture. These are the 3 different types of dressings. Changing the dressing is on page 1181. So you want to prepare your patient, explain to them what you're doing, and make sure you get permission to proceed. Use appropriate aseptic techniques. Wash hands before and after. You want to adhere to standard and transmission-based precautions. Remove the old dressing. Cleanse the wound. You want to wash your hands, reapply clean gloves, and then you want to apply the new dressing and secure that dressing. And date and time and initial that dressing, not while it's on the patient's body, but prior to applying it. Cleansing the wound, pressure wound or injury. So cleanse with each dressing change. Use new gauze for each wipe and cleanse from top to bottom or from the center to the outside. So I recommend going from center to outside and use a separate gauze for any intact skin versus the skin that is not intact. Use normal saline solution to irrigate and cleanse the injury. Sometimes your facility may have something called a wound cleanser solution. Once the wound is cleansed and dry, dry the area using a gauze sponge in the same manner. You're just patting dry. Report any drainage or necrotic tissue. So types of bandage. So on 1185 to 1186, it talks about securing wound dressings, and it begins with the types of bandages. On 1185, it actually in the paragraph describes these different types here listed. So a roller bandage, circular turns, spiral turns, figure 8 turns. And then on page 1186, it shows us the different techniques for these bandages. Okay. So on 1185 through 1187, the beginning of 1187 is talking about these types of binders, and it's showing us pictures of these different types of binders on 1186. Types of drainage system. So our open system is a Penrose drain, and it is soft and flexible. This drain does not have a collection device. Instead, a absorptive dressing is used to collect the secretions. So it promotes drainage passively by allowing the drainage to move from an area of greater pressure in the wound or surgical site to an area of less pressure, the dressing. It is not sutured in place. It is largely a sterile procedure. A sterile paper safety pin is placed there, and the care for this is a sterile procedure. So it may be trimmed down according to the orders, and that is with sterile scissors. Okay, this is considered an open drainage system. And then you have our closed drainage system, which includes our Jackson Pratt drain as well as our Hemovac drain. Both of these drains are sutured in place, and the Jackson Pratt is they're both under a constant low suction. So the Jackson Pratt bulb must be decompressed so that suction occurs, drawing out the fluid from the insertion site. Usually is a surgical wound. That bulb is emptied and decompressed. And then we have our Hemovac drain, which is also a manual low suction. And that lid is open, the drainage is emptied, and that Hemovac is decompressed again. The drainage that's removed is measured and it is documented according to the description of the exudate, whether it's serosanguinous, right? Purulent, and the amount, and whether there is an odor. Here's a picture of our Penrose drain. Here's a picture of our Jackson Pratt. Okay, so before we begin our classification of open wounds, I did want to call your attention to Table 33-4 on page 1172. It talks about common types of drains. So we have open and then we have closed. So I would read through that and it tells you the types of drains. It also tells you the purpose and it gives you an example. Okay. Also, I want to call your attention to 1191, Teaching Tips 33-1, Wound Care and Healing. So the health topics are supply, infection prevention, and wound healing. Then it has teaching tips for all. And then it explains why they're important. So for infection prevention, I want to call your attention to the bullet that speaks about hand hygiene before putting on and after removing disposable gloves. Very important. So hand hygiene before starting wound care and putting on gloves, when changing gloves in between dirty and clean dressing or removal of old dressing and new dressing application, and then hand hygiene after completion of the entire wound care. Very important. All right, so wound classifications are located on page 1171. 1171, and it is box 33-5. RYB wound classifications are described in a small paragraph for each. So we have red or protect. So red wounds are in the proliferation stage of wound healing and reflect the color of normal granulation tissue. You have our yellow, which stands for cleanse. Yellow in the wound may indicate the presence of exudate, drainage, or slough and requires wound cleansing. You have black or debris. Black in the wound may indicate the presence of eschar tissue, which is usually black in color. It could also be brown, gray, or tan. And black requires debridement or removal of that tissue before wound healing can begin. Then you may have a mixed wound containing components of both red, yellow, and black, or R, Y, and B in the wound. Topics for home health care teaching begins on page 1190. So you want to teach your patient about supplies, infection prevention, wound healing, appearance of skin, recent changes, any changes in the skin, activity and mobility, the importance of good nutrition, um, the importance of reporting any pain or elimination issues. So the teaching goes into page 1191, and also remember the teaching tips that I referred to. The hand hygiene is very important. However, I want you to read this entire box for teaching tips 33-1. Is affecting the response to hot and cold treatment begins on page 1194, continues into page 1197. So first it talks about different types of heat that could be applied. So I do want to mention that heat is usually applied by PT in the rehab setting. They have a device where they can set and regulate the temperature and they can monitor the patient closely to prevent burns. However, in the event that heat is ordered for your patient, the temperature should be between 105 and 109 Fahrenheit, and this device should not be on the patient any longer than 20 minutes. So, according to your text, it's between 15 and 20 minutes. There are 4 bullets on page 1195. On the right hand side, if a warm soak is prescribed, they have general guidelines. And so, read through those 4 bullets. When applying cold can be applied for hypothermia to help, a therapeutic hypothermia to help decrease a patient's temperature. Okay. Um, ice is also applied 15 to 20 minutes as well. And this application can be every 2 to 3 hours as ordered. Okay, so 15 to 20 minutes will prevent hypothermia or any prolonged exposure to cold complications related to that. If this is a home setting, you can educate your patient. They could put a frozen bag of vegetables, such as peas, and use that as an ice bag. So read through both moist and cold applications. So on this slide, it talks about method and duration, which we mentioned, the degree of heat and applied age and physical condition can be a consideration, and amount of body surface that is going to be covered with this heat or cold application. The effects of applying heat is on 1193. So it dilates the peripheral blood vessels, increase tissue metabolism, reduce blood velocity, and increases capillary permeability, reduces muscle tension, and relieves pain. Effects of applying cold is also on page 1193. It constricts peripheral blood vessels, reduces spasms, and promotes comfort. So on page 1194 through 1195, I referred to the different heating devices, apparatus. So we have hot water bags, electric heating pads, aquatherma pads, hot packs, warm and moist compresses, sitz bath, and warm soaks. So these are all described in these 2 pages, and it's a small paragraph for each of them. Read it. For our devices to apply cold, it begins on 1195 and extends into 1197. So we have our ice bag, our cold packs, hypothermal blanket, cold compress to apply moist cold. So they all have a small paragraph describing them. Please read those paragraphs as well.